Hello doctors, today we are going to talk about one of important and common lesion we face. Oral ulceration is a complete loss of epithelium, the surface of the oral mucosa. It could be simple and self-healing, or it could be a sign of a big problem. That's why we need to learn how to examine it carefully. Take a good history and when to take biopsy. There is a rule that any ulcer take more than 3 weeks should be sent to histopathological examination. Ulcers have 8 important characteristics. 1. Site. The site often points to the underlying cause: traumatic, systemic, viral, malignant. 2. Single or multiple ulcers usually point to a systemic, infectious, immune-mediated, or hematologic cause. 3. Size. Larger ulcer indicates more severe condition or a potential malignancy. 4. Shape. Round or oval, regular or irregular. 5. Base of ulcer yellow or gray, red or bleeding, indurated. 6. Edge suggest chronic or healing. 7. Pain. Sharp or burning, dull, painless. 8. Time period. Traumatic ulcer caused by trauma. Could be chemical as aspirin topical use, or mechanical due to sharp cusp or cheek biting or ill-fitting prosthesis. The center of the ulcer is reddened erythematous, covered with yellowish fibrin or purulent membrane, and the border is white hyperkeratotic. The treatment is the removal of the cause and symptomatic treatment with 0.2% chlorhexidine mouthwash. The ulcer healed within 2 weeks. Aphthous ulcer is the most common type of ulcers, more common in exams time. Period. Smoking cessation. It is also associated with deficiency of iron, folic acid, vitamin B12. Small ovoid or circular, less than 1 centimeter. Regular and defined, not as traumatic ulcer. Heals within 14 days. Doesn't leave scar. Could be from 1 to 5 ulcers. Has high recurrent frequency. Major aphthous ulcer. Large, painful and deep. Affects the posterior part of mouth and involve keratinized sites. Single. Large, more than 1 centimeter. Takes several weeks to heal. Require topical or systemic therapy. Topical corticosteroids, tramisancy and acetones 0.1% or clobidasa. Chlorhexidine mouthwash. Topical anesthetics, lidocaine.
Herpetiform ulcers are the least common, but most painful subtype of recurrent aphthous stomatitis. Despite the name, they are not caused by herpes virus. The pattern just resembles herpetic infection. Multiple small, round ulcers. From 10 to 100. Healed within 10 to 14 days. The difference between recurrent aphthous and herpes virus. The anatomical distribution. Aphthous recurs at different sites inside the mouth. Herpes simplex recurs in same location due to nerve ganglion latency. Aphthous ulcer occurs on non-keratinized mucosa only, buccal mucosa, labial mucosa, floor of mouth, ventral tongue, soft palate. Herpes simplex occurs on keratinized mucosa, attached mucosa, hard palate, attached gingiva, vermilion border, cold sores. Behçet syndrome. A chronic, relapsing, multisystem vasculitis involving small and large vessels. Classic triad. 1. Recurrent oral aphthous ulcers. 2. Recurrent genital ulcers. 3. Eye inflammation, uveitis. But Behçet can involve many systems. It is a widespread disease with potential cutaneous, articulator, vascular, cardiac, pulmonary, gastrointestinal, and neurological involvement. Oral ulcers. Recurrent aphthous-like. Painful. Major diagnostic clue. Similar to RAS, recurrent aphthous stomatitis, but more severe. Idiopathic causes. Likely autoimmune. Traumatic granuloma. A chronic, persistent ulcer of the oral mucosa caused by trauma, often with a deep inflammatory response that may mimic malignancy. Persistent ulcer does not heal within 2 weeks. Indurated, raised or rolled borders can resemble oral cancer. Painful or non-painful. Usually single lesion. Common sites. Lateral tongue, most common. Buccal mucosa. Lip mucosa. Surface, yellow-white fibrinous base. Confirmed by biopsy if lesion looks suspicious. Always rule out SCC in chronic ulcers within duration. Treatment. Eliminate trauma, smooth tooth edges, adjust prosthesis. Topical corticosteroids to reduce inflammation. Most heal within 1 to 3 weeks after removing the cause. Bacterial-associated ulcers are less common, but important to recognize. Syphilitic ulcers, Treponema pallidum. Tuberculous ulcer, Mycobacterium tuberculosis. Necrotizing ulcerative gingivitis, NUG/ANUG. Gonococcal stomatitis, Neisseria gonorrhoeae.
Syphilis causes different types of oral lesions depending on the stage of the disease. Keycap 1 Primary syphilis, chancre. Features. Painless ulcer, very important. Indurated, hard, border. Clean base, not necrotic. Usually single lesion. Appears 10 to 90 days after infection. Common oral sites. Lip, most common, due to kissing/oral sex. Tongue. Buccal mucosa. Palate. Other clues. Regional painless lymphadenopathy. Keycap 2 Secondary syphilis, mucus patches. Features. Shallow, painful ulcers. Soft, gray-white patch with red border. May coalesce snail track ulcers. Highly infectious. Appearance. Soft, velvety, oval erosions. Often multiple. Sites. Buccal mucosa. Tongue. Soft palate. Lip mucosa. Keycap 3 Tertiary syphilis, gumma. Features. Deep, destructive ulcer. Punched out or crater-like. Can perforate the palate. Not painful initially but becomes painful later. Not infectious, immune-mediated. Sites. Hard palate, classic, may perforate. Tongue. Oropharynx.
Gonorrhea can cause ulcers or erosions on the oral mucosa, erythema, red patches, pseudomembrane in severe cases, halitosis, pain during swallowing, lips and gingiva, redness, swelling, rarely, ulceration around the lips, typically in sexually active young adults, history of oral sex, cervical lymphadenopathy, necrotizing ulcerative gingivitis, NUG, also called trench mouth or Vincenz infection, a rapidly progressive, painful, destructive gingival disease caused by anaerobic bacteria such as Spirochetes and Fusobacterium and worsened by poor immunity, affecting the gingival margins and interdental papilla, in particular the lower anterior region. Precipitating factors: tobacco smoking, stress and immunodeficiency, HIV, mechanical cleaning and debridement of the teeth in affected area, metronidazole 400 mg 3 times, amoxicillin 500 mg 3 times daily.
Oral TB is rare, usually secondary to pulmonary TB, but primary oral TB can occur. Caused by Mycobacterium tuberculosis. And it is one of the most prevalent infectious diseases in the world, particularly in developing countries. Chronic, painless or mildly painful ulcer. Deep, indurated, irregular edges. May bleed on trauma. Non-healing, persisting weeks to months. Often single lesion. May be associated with cervical lymphadenopathy.